Welcome to my third episode of End of Life Journey with Hospice. Today, I would like to elaborate on the last stages of terminally ill patients. Every individual has a different prognosis based on the diagnosis of the illness. Through my close observations of most patients after reaching fourth stage of their diagnosis, and as chemotherapies or invasive treatments are not an option anymore, they manifest many symptoms of complications as a result of chemotherapies they had previously received. One of the worst symptoms is the immune suppression, causing decrease in patients' body defense mechanism, making them weak with loss of appetite and lack of energy due to nausea and vomiting. Also, bowel functions are distorted with extremes of either constipation or diarrhea. At this stage, most of these patients are sent home with given life expectancies of 2 to 3 weeks or 1 to 3 months to live. As I have outlined in a previous episode, my philosophy of hospice practice has been to support these patients to treat their symptoms, focusing to enhance their immune system and boost their energy by improving and increasing their appetite, resolving their nausea, vomiting, and normalizing their bowel function. Always striving to enhance some quality of life so they can build as many important and good memories with their loved ones in their last few weeks or months of their lives. They can communicate their thoughts and resolve differences among family members, bringing them together stronger than ever, being reassured that everything is taken care of before they are ready to leave this world. In the last month of their lives, patients start having visitations, seeing the spirits of their past loved ones who have passed away. As patients mention these visions, they are referred to as hallucinating and being confused by the family members. When patients realize that these visions are real only to themselves and that the family members are not open to understanding these visions, as a result, they become withdrawn, nonverbal, and avoid sharing these important messages with their family members, building a wall of silence and become very selective and limited in their communication with their loved ones. These last 2 weeks are part of the rapid decline in the end of life cycle of these patients, where eating stops gradually and patients start taking only small amounts of fluids and gradually taking only sips of water as oral intakes. Patients also become gradually very lethargic, unresponsive to verbal and tactile stimuli. By this time, patients progressively becoming hypoxic are started on oxygen treatments as needed for their proper oxygenation. Some patients also have the terminal body fevers for a few days and become very diaphoretic, even with the use of Tylenol suppositories prescribed with their comfort pack. They also become increasingly incontinent with loss of bladder and bowel functions. Pain is very individual to patients' diagnosis. Not every terminally ill patient will experience pain at any stages of dying cycles. For example, patients diagnosed with Alzheimer's or dementia, they will never sometimes have pain, even at the end of their life cycle. Personally, I consider this as a blessing in disguise for these patients. Pain is mostly quantified in the last month of the terminal illness, especially if it involves metastasis to bones, pancreatic, hepatic, duodenal, and gastric bile ducts. Again, with my philosophy, pain management is provided to these patients, focusing on their individual level of pain tolerance to provide the proper medications to maintain them pain-free and yet not over-sedate them in early stages of hospice care so that they are kept as alert and functional as possible. As patients near their last 2 weeks of life, the pain medication is again provided only to keep patients pain-free. Imminently dying stage is the last week of the patient's life. Patient's breathing cycle changes, starting with short apneal cycles, followed by hyperventilation or tachypnea. These apneal cycles become increasingly longer. At this stage, patients are on oxygen via face mask at 5 liters per minute due to mostly mouth breathing and becoming very hypoxic. Also, at this time, most patients are provided with continuous care around the clock, 24/7, by experienced nurses attending to patients' needs with use of breathing therapies, suctioning as necessary, and administering medications of comfort measures as are prescribed for the patient. Emotional support and guidance are very important and provided to dying patients and their family members as needed. Educating family members to talk to patients, informing that sense of hearing is the last of the senses that will leave patients and that patients could still hear them until their last breath. I would like to present examples of these patients' end-of-life cycles with different situations and help to understand the necessary coping skills to achieve the healthy closures for end-of-life experiences. I would like to share a very short episode from these examples of a patient in hospital setting whom I had been providing the renal replacement therapies for his end-stage kidney failure and severe congestive heart failure, using CPAP during sleep and sometimes during his dialysis treatments. During the last 2 weeks of his life, I noticed the patient was looking up into the 2 different corners of the ceiling in his room. After several gazing episodes, I started questioning patient what he was staring at the corners of the ceiling. Initially, patient was reluctant to disclose his vision. Then, with his trust in me, as I smiled to him, he started pointing out to the left corner of the room ceiling, giving that person's name, stated that he was his friend, but he was a very bad person in his life. Then pointing to the right corner of his room ceiling, stated that there were 2 of his friends who also had passed away, but these were very good people. Acknowledging his vision gave the patient the freedom to verbalize his feelings further by calling out to their names and talking to them. Patient started scolding the bad friend, pointing his finger towards him, saying, "Get away from me. I'm not ready for you. I'm not ready to go with you. And I will not go with you even if I'm ready to go." This continued every evening when patient was talking to these spirits in my presence, scolding the bad one in the left corner and remembering some life episodes with the good ones in the right corner of the ceiling in his private room in the hospital. Patient passed away 2 weeks, and right after my last dialysis treatment to him. He was alone in the hospital, away from his family. He had requested for me to provide his dialysis treatments until the end of his life. I feel these patients need to be in their homes with their loved ones and be able to do the end of life closure with healthy bases to be remembered. I will present more and more of these examples of patients which I have had my experiences taking care of them in their home environment, and detail every single experience that I have observed in my time with them, with their family, educating and supporting all of the family members. It is very imperative for a patient to die at home among loved ones and be able to do the healthy closure at end of life cycle the way it's supposed to be. Until our next episode, please stay safe and healthy, and thank you for listening again.